It is my pleasure to introduce our speakers, Dr. Jatinder Bhatia and Amy Gates of the Medical College of Georgia School of Medicine in Augusta, Georgia. During today's webcast, Dr. Bhatia and Ms. Gates will discuss strategies the nutritional team can use to support the breastfeeding relationship and assure successful outcomes. They will also examine the situations in which breast milk fortifiers should be considered, the compositional differences among fortifiers, the studies for and against their use, the optimal duration of fortification, as well as long-term effects and cost analyses. If you have a question that you would like to ask one of our presenters, you may type it into the question field on your viewing screen at any time during this on-demand presentation. For a period of time after the release of this webcast, a moderator will monitor this site for questions and will submit selected questions to the faculty. Please note that because of the potential volume, faculty will not be able to answer every question, and your question may be combined with similar questions. Answers to questions will be posted periodically in groups and may be accessed by going to this activities page on the Pediatric Nutrition CE.org website. Eventually, the question and answer session will be closed, but learners will be able to browse through questions that have already been posted and the answers that were provided. Dr. Bhatia, you and Amy Gates may begin your presentation.
Thank you. Welcome, everybody, to this webinar examining the evidence for human breast milk and fortifier in infants. Let's start with the nutritional goals for premature infants. Adequate nutrition to satisfy growth needs is important because failure to do so may result in irreversible deficits. Generally acceptable goal is to provide sufficient nutrients to achieve postnatal growth approximating that of normal fetus of the same postmenstrual age. Is it possible? Should we have catch-up growth? Until then, we need to use the last point, which says maximum possible gain without adverse effects. In this slide, we put together evidence-based early nutritional practice for very low birth weight infants published a few years ago. And basically tells you that prompt provision of energy, prompt provision of amino acids are both recommended, and the qualitative evidence is a B. Initiate lipids by 30 hours of life, recommended, qualitative evidence B. Initiate trophic feeds by 5 days, recommended, qualitative evidence B. Essentially means early aggressive nutrition followed by enteral nutrition as soon as possible within the first 5 days of life. The nutrition needs for premature infants can be further categorized by looking at what are the entities that promote weight gain, lean body mass, or fat gain. For example, weight gain is affected by protein-energy ratios. This is very important to keep in mind that optimal amounts of protein should be provided in the face of optimal energy needs, otherwise you will have adverse effects. So protein intake is associated with weight gain as well. Lean body mass, which is an indicator of appropriate nutrition, is largely affected by protein intake. Fat gain, on the other hand, is influenced by energy intake, and if you provide altered protein-energy ratio, by which I mean less protein, too much energy, the excess energy goes to fat. Fat gain is easy to achieve, but may not be the optimal gain to achieve. Human milk, we've known for a long time, is species-specific. Is adapted through evolution to meet the nutritional needs of the human infant. But survival of premature and extremely premature infants is increasing. Premature births are increasing, at least in the United States. And human milk, preterm or term, is limiting in various nutrients for the optimal growth of the premature infant, and thus the importance of understanding the dynamics of human milk and its fortification. This statement is from the American Academy of Pediatrics, pertains largely to term infants, which basically says breastfeeding and human milk are the normative standards for infant feeding and nutrition. Given the documented short and long-term medical and neurodevelopmental advantage of breastfeeding, infant nutrition should be considered a public health issue and not a lifestyle choice. The American Academy of Pediatrics reaffirms its recommendation of exclusive breastfeeding for about 6 months, followed by continued breastfeeding as complementary foods are introduced, with continuation of breastfeeding for 1 year or longer as mutually desired by mother and infant. If you take that further to premature infants, human milk also is a preferred feeding, but it has issues which we will discuss in this webinar. The benefits of human milk are well known to all of you: immunity, better neurocognitive development, better gastrointestinal maturation, a significant reduction in necrotizing enterocolitis, sepsis, especially late-onset sepsis, and alteration in lipid profiles, which are beneficial in the human milk-fed infant. Fat absorption. Human milk contains its own lipase, which is an advantage because it improves fat digestion. Triglycerides in human milk are broken down into free fatty acids and glycerol by bile salt-dependent lipases found in human milk. The fat in human milk is reflective of the dietary fatty acids of the mother's diet. Therefore, it's important to pay attention to a mother's diet, especially when it comes to lactation. A fatty acid supplement, therefore, containing DHA, ARA, will improve the profile in the mother and will improve the DHA, ARA content in human milk. And the next step would be, when you use fortifiers, we should choose fortifiers that contain DHA and ARA because that is extremely important for premature infants. Protein. The average protein requirement for preterm infants is estimated to be between 3.2 and 4.5 grams per kilo per day. Extremely low birth weight infants and very low birth weight infants require a minimum of 4 grams per kilo to achieve an intrauterine type growth pattern. Remember what I just said, achieve an intrauterine type growth pattern, because there are a lot of external influences which you may not be able to achieve the same growth pattern as in utero. Human milk contains 70% whey and 30% casein for ease of digestion. But it's important to remember the protein content varies by number of days postpartum. Preterm human milk initially contains more protein, approximately 2.1 grams per kilo, than term infants. Than term human milk. We may be overestimating the amount of protein in human milk because it's a dynamic nutrient, and nutrient content of protein changes over time, and we are always using a fixed amount of protein in human milk, which may not be the appropriate thing to do. Human milk and neurocognitive outcome. It's been demonstrated for a long time that human milk feeding has an 8-point IQ advantage at 8 years of age. Other studies have shown better visual acuity compared to preterm formula. Benefit appears to be dose-dependent, with infants consuming human milk in the highest quintile, approximately 110 ml per kilo per day, demonstrating the greater advantage. In other words, there's a dose-response relationship. Similar advantage has been demonstrated in a large NICU trial where higher growth velocities for weight and head circumference were associated with better outcomes at 18 to 22 months. Therefore, human milk has advantages, better growth has advantages, and that can be achieved with appropriate management. The protective qualities of mother's milk comes from things like lactoferrin, which is bacteriostatic, is present in human milk, lysozymes, which lyse cell walls, secretory IgA, which is protective, oligosaccharides offer protection and foster lactobacillus bifidus, the friendly bacteria, if you will, and contains a variety of hormones and growth factors, which makes human milk optimal. Going on to more properties and components of human milk, it is anti-infective factors. For example, there are more white cells per milliliter than there are in blood in the first 10 days of life. Macrophages and neutrophils are among the most common leukocytes in human milk. They surround and destroy harmful bacteria by their phagocytic activity. Secretory IgA and interferon are important anti-infective agents produced in abundance by lymphocytes in human milk. Lactoferrin is an antimicrobial glycoprotein present in colostrum, and that's one of the key things about feeding colostrum as well, which we'll talk about later. It's a key component of the mammalian innate response to infection. Has broad microbial activity against gram-positive cocci, gram-negative bacilli, and Candida species. Has prebiotic properties, creating an enteric environment to promote the growth of beneficial bacteria and reduce colonization of harmful bacteria. Prebiotics, typically a mixture of galacto and fructo oligosaccharides. They support the growth of probiotic lactobacillus and bifidobacteria species in the bowel, the type of bacteria we want. prebiotic substances are naturally present in breast milk and are resistant to gastric acid digestion. A new thing that's happened in the last couple of years is the colostrum swabbing for extremely low birth weight infants. Typically, these babies may not be fed enterally for a few days. However, this pilot study demonstrated that by using colostrum swabbing is safe and may be effective in promoting immunity and gastrointestinal health. More studies are needed to address this question. So the colostrum can be provided even when the infant is NPO, can begin immediately after colostrum is available, and swabbed every 3 hours for the first 7 days of life. As the mother's milk comes in, it can switch over to enteral feeding. It essentially provides the infant's first vaccine. The colostrum swabbing is an oral pharyngeal administration of mother's milk. It's easy, inexpensive, and well tolerated by even the smallest and sickest, extremely low birth weight infants. Future research will continue to examine the optimal procedure for measuring direct immune effects and clinical outcomes such as infection, particularly ventilator-associated pneumonias, would be an important next step. This is an example of the dose-response relationship I talked to earlier. This looks at 3 outcome measures: NEC, sepsis, and late-onset sepsis. And you see in each of the categories, babies fed human milk greater than 50 ml per kilo per day demonstrated an advantage compared to human milk plus fortifier or preterm formula. So that's a protective effect of human milk in the dose-response relationship, and the minimal threshold in that study was 50 ml per kilo. Newer studies have shown that more human milk, mother's milk, can provide better the immune properties and better the infection rate and NEC rate and late-onset sepsis rate. I'm going to hand over to Amy Gates to continue the next part of the presentation.
So whenever we don't have adequate mother's milk, which is always an issue in the neonatal intensive care unit as women have decreased lactation over time, we're looking for an alternative to mother's own milk. Donor milk can be an alternative to infant formula when an adequate supply of mother's own milk is not available. Keep in mind that donor mothers are screened extensively, must be drug-free, alcohol-free, and tobacco-free. They are also tested for diseases. Keep in mind that the donor milk is pooled and pasteurized, with the reason for this being that to get a better standardization of calories and fat across the donors. The milk can be available in preterm. Typically, this is in very short supply because preterm milk comes from typically bereaved mothers, and there just are not that many mothers who can provide the preterm milk. So most of the milk that you'll receive from a donor milk bank will be that from term infants, typically between 4 and 12 months postpartum. One of the barriers to providing donor milk is the cost. It ranges in dollars from $4 to $6 per ounce. Some of the trends that have been popular in the last several years with human milk banking are the International Breast Milk Project does ship a lot of the donated milk from our milk banks to developing countries such as Africa to provide a safe form of feeding for infants who have either lost their mothers or have mothers with HIV. To date, there's been more than 200,000 ounces of donated milk shipped around the world. And what this does for our human milk banking is reduces the amount of milk that is available here in the United States. To date, 75% of the milk from ProLacta Bioscience has been used for manufacturing fortifiers for preterm infants. Donor milk is also being used in research. And there's a growing trend among physicians to use the pasteurized donor milk for older infants, toddlers, and even in some cases adults. So having said all of that there is a limited number of human milk donors. Donor milk, the way that milk is donated for donor milk banking is much different than, say, blood donation, in that it does take a lot of screening and pre-preparation before a mother can become a donor. It's not like with blood donation where a woman can just walk in and donate on the spot. It is. So that limits the number of human milk donors that we have available. And so there is not enough donor milk to feed all infants who are not receiving mother's own milk. It is our opinion that the pasteurized donor Human milk should be allocated first to the very low birth weight infant in the NICU because those are the babies who will receive the most benefit. Keep again in mind that the preterm donor milk is in very limited supply, so the milk is typically very low in calories and protein and is inadequate to meet the need of the very low birth weight infant without the addition of a fortifier. So, and the benefits of providing preterm pasteurized donor milk to term infants has yet to be proven. Looking here at Dr. Chandler's study of infants that were less than 30 weeks gestation who did not have adequate supply of mother's own milk, and they were randomly assigned to receive pasteurized donor milk or preterm infant formula. When the groups were compared, the infants who received mother's own milk had a significantly shorter hospital stay, 15 days less than those infants who received preterm formula, as well as fewer cases of chronic lung disease and less mechanical ventilation when compared to the donor milk and preterm formula groups. Looking next at other outcomes, the fewer cases of NEC, the mother's own milk, a 4% rate of NEC versus 10% for the preterm formula and 5% for the donor milk, suggesting that mother's milk is more protective, obviously, than formula and more protective than pasteurized donor milk. When comparing the growth parameters for mother's milk versus preterm formula and donor milk, there was a significant difference in weight gain among the preterm formula group, and there was a length difference in the donor milk group versus the mother's milk group, which the reason for this is unclear. So 17 of the 81 infants in this study that were fed donor milk had to be switched to preterm formula because of poor weight gain, which is something we see commonly in the NICU because, like I said before, the donor milk is typically a lower calorie, lower protein milk because of the number of days postpartum. They also saw no difference between donor milk-fed infants and formula-fed infants in late-onset sepsis, necrotizing colitis, hospital stay, or death. Mother's milk-fed infants did have fewer episodes of NEC and fewer episodes of sepsis. So when comparing several studies to each other in donor milk and NEC, there is an improvement in the percentage of NEC among infants who receive donor milk versus preterm formula. So some of the concerns with using donor milk are the effects of storage, and we know that the milk is frozen, and 2/3 of the original bacterial activity in the freezer is intact at 3 months. Refrigerator storage up to 96 hours maintain the secretory IgA, lactoferrin, as well as the balance of the colony counts. The milk from donor human milk banks is pasteurized using the Holder pasteurization method, which does inactivate CMV. But doing this does lose somewhere between 0 to 30% of some of the secretory IgA and the bifidus bacteria as well as lysosomes. So the author concluded from this study that because donor milk and preterm formulas infants receive 50% of their milk as mother's milk, it seems that a greater dose of mother's milk is needed to enhance protection of extremely premature infants. Because substitutes for mother's milk are not optimal, the data suggests that alternative strategies should be sought to enhance mother's milk production and to provide adequate supply through hospitalization. So there are some indications for the use of pasteurized donor milk, and we are all encouraging the use of the human milk diet as a standard feeding for the very low birth weight infant. The reality is that not all moms will choose to provide their milk as well as not have adequate supply. So in absence of mother's milk for the extremely low birth weight infant, we can see an improvement by using donor milk and compared to infant formula in this population. Pasteurized donor human milk seems to reduce neonatal infections and NEC in comparison to infant formula. But we obviously need to pay more attention to increasing the number of women who provide mother's own milk and not focus so much on the donor milk as the substitute. And we can increase the number of women who do provide their own milk with a few simple things in terms of encouraging bedside pumping, encouraging skin-to-skin exposure or kangaroo care, which may help with milk volume, allowing the infant to taste his mother's breast milk during gavage feedings, either by doing the colostrum swabbing using a pacifier to dip into the milk and allow the baby to taste it, allowing the baby to do kangaroo care at his mother's breast. We also need to be providing support in a breastfeeding-friendly environment, such as making sure that we have adequate supplies of breast pumps and breast pumping supplies. Skin-to-skin holding and maternal milk volume is also very important, because if you look in this study, you can see that the women who did more skin-to-skin holding, more kangaroo care, if you will, had significantly higher amounts or higher volumes of milk than those women who did not. An important piece to remember in maintaining milk supply for your mothers are the types of breast pumps and how the mother's educated in removing her milk, because the number one complaint of women, or number one reason why women stop providing breast milk for their preterm babies, is a lack of supply. Hand expression can be used for the retrieval of small amounts of colostrum. This is something that can be done immediately after delivery that doesn't require a breast pump. But for long periods of time, when women are separated from their babies and are not able to actually put their babies to breast, a hospital-grade double electric breast pump will typically work best for those women. So the breast pump is fundamental to providing adequate mother's milk and promoting better milk supply.
So the nutrient recommendations from one source are depicted on this slide. For example, for babies less than 1,500 grams, you need approximately 108 to 127 calories, whereas the premature infant less than 1,000 grams needs over 105 to 119 calories. Similarly, protein intakes range from 2.6 to 3.8 for the babies less than 1,500, and 2.5 to 3.4 for the babies less than 1,000 grams. Carbohydrate, grams per 100 calories, is depicted as well, and so is fat, which is similar for the two age groups. The ESPGHAN, which is the European Society, its recommendation is slightly higher. The fluid intakes range from 135 to 200 ml per kilo per day. Energy, 110 to 135. Remember, energy is a guide, and one needs to optimize energy with protein to promote optimal weight gain. Protein, they recommend for less than 1 kilogram baby, 4 to 4.5 grams per kilo per day, which is what we practice. And for 1 to 1.8 kilograms per babies are recommended to have 3.5 to 4 grams per kilo per day. Iron is limited quantity in breast milk, is very important supplement to have, 2 to 3 milligrams per day. Vitamin D, 800 to 1,000 units, which is slightly higher than the recommendations for the United States. Calcium, 120 to 140 milligrams per kilo per day. And phosphate, 60 to 90 milligrams per kilo per day. On this slide, I'm going to show you in the traditional feeding pattern what happens to babies who are less than 30 weeks or greater than 30 weeks. For example, you see on the bottom part, it shows you the cumulative deficit of protein over a 5-week period. If you look at the next one, you look at the babies who are less than 30 weeks, you look at the remarkable deficit that occurs over the 5 to 7 week period, demonstrating that we are not able to provide appropriate amounts of protein to meet the nutritional goals that we set forth in the beginning of the presentation. Similarly, energy intake is depicted in this slide. For the larger babies, we seem to do pretty well, but the cumulative deficit is relatively small. However, for the smaller babies, the deficit is very similar to that occurs in the protein, and we have an accumulative deficit of energy over the 7-week period similar to that of protein that I showed you in the previous slide. So to summarize these two slides, we basically have a deficit of protein and energy. This is the reason why extrauterine growth restriction becomes so common in the babies less than 30 weeks. In this slide, the question of catch-up growth is depicted. For example, in the top panel, Group 1 is fed about 2.4 grams of protein per 100 calories. Group 2 is fed 3.2 grams of protein per 100 calories, and Group 3 is 2.7 grams per 100 calories. But the energy intakes are different, 119, 120 for the Group 1, Group 2, and 142, far higher than the recommended ranges for Group 3. The result of this, you see a significant increase in weight gain of 21.5 grams mean in Group 3 compared to 16 grams in Group 1. There's no difference in length or head circumference. But the most important factor here is skin fold thickness, which is a proxy for fatness. And you notice that group 3 has the highest skin fold thickness of 1.22 millimeters per week compared to 0.69 in group 1. So to achieve catch-up growth means in the current generation of feeding strategies that we will have to increase fat gain. The long-term implications of this are not known, and one doesn't necessarily want to have catch-up growth at the expense of fat gain. So the limiting nutrients in human milk, as we mentioned before, energy. Fat content differs during lactation, throughout the day, between and within the mother. It's also affected by how effective the breast pump is, because more you empty the breast, more you get the hind milk, which is better in fat. You get loss of fat from separation. This is especially important when you're feeding. Donor milk also has a wide variation leading to batching. So that's why you get donor milk in batches which says so many calories or so much protein. The variability also is due to collection, storage, and the method of feeding, whether you're feeding continuously or by gavage. Protein content declines in both preterm milk and term milk. And after 2 weeks, preterm milk is essentially undifferentiated from term milk, and the protein content is low, and the energy content also declines. But the nutrient needs remain higher. There is one big argument for fortification. And this is evidenced by decreased BUN, prealbumin, albumin, and total protein, which decline if you feed unfortified human milk. Remember that sodium may be growth limiting because babies may become hyponatremic because human milk has low amounts of sodium. Zinc deficiency is well recognized over long periods of time, as are vitamins A and C and riboflavin, but those are easy to overcome. Calcium and phosphorus are extremely important. Although they are well absorbed, they're inadequate quantities in human milk. If you feed human milk unfortified, it's not a question if I'm going to get rickets or metabolic bone disease. It's a question of when am I going to show metabolic bone disease. Phosphorus becomes rate limiting. There's a progressive decrease in phosphorus. You start seeing increase in alkaline phosphatase. Premature babies are already osteopenic at birth because calcium was transferred actively in the third trimester of pregnancy, and therefore it's a setup for metabolic bone disease. This results in reduction in attained height and long-term bone mineralization. So the goals of fortification of human milk are to achieve appropriate weight, length, and head circumference gain and body composition. And remember what I told you earlier, length is an index of lean body mass. If you add this to the benefits of mother's own milk, which Amy talked about, necrotizing colitis, sepsis, length of stay, and better neurocognitive development, this may be a plus-plus. We also have to question over time as we do more studies, does it affect adult-onset disease because of the protective effects of human milk in the human infant? There's another way of looking at protein intake recommendations with or without catch-up growth. For example, Rigo and Santier published a few years ago that 26 weeks, for example, 26 to 30 weeks, you need 3.8 to 4.2 kilograms per kilo per day without catch-up growth, and need about 4.4 grams per kilo per day for catch-up growth. Similarly, for the larger gestation, you also make an incremental change to achieve catch-up growth. The fortification of human milk, the preferred option, which is not available to everybody, is to analyze the milk and then appropriately fortify it for the whole batch for the next 24 hours. People have tried either fixed fortification, i.e. so many packets per 100 ml of milk, or variable fortification, for example, according to blood urea nitrogen. But this study found no differences in weight gain, and there was a high frequency of lab measurement, so the appropriate option may be analysis and appropriate fortification based on what you find. There are several ways to fortify human milk, and I'm going to point out some of the ones that are done and why it should not be done. For example, single versus multi-nutrient fortification. For example, people would add, just say, MCT oil or some carbohydrate source. There's an increased risk of dose error, changes in osmolality, which may affect the baby, and therefore commercially available fortifiers, which are the multi-nutrient fortifications, are the most practical. Human milk fortifiers are now available, and they're very expensive. We can discuss that later. But the Cochrane review done a few years ago 600 infants, babies less than 1,850 grams, suggested that there's improvement in weight gain, length and head circumference, and bone mineral content with multi-nutrient fortification. Many studies have been done. I'm just going to mention them for completion. They've demonstrated advantages of protein energy supplementation, calcium and phosphorus supplementation, protein only, and the bone mineralization is equivalent to fortified versus formula. But poorer weight gain, equivalent length and head circumference have been seen compared with preterm formula, suggesting that the fortification was not optimal. There are no studies on simple carbohydrate supplementation as far as the last Cochrane review available. The human milk fortifier, which Amy will discuss a little later, demonstrated improved weight gain, but associated with lower serum phosphorus and higher calciuria, suggesting the onset of metabolic bone disease. Formula milk versus term human milk, better growth of formulas, limited data to allow definite conclusions because we already mentioned that term human milk has very low protein content and therefore is not appropriate to be fed unfortified to preterm infants.
So when we look at what our options are in terms of fortification of donor milk and mother's own milk, one of the options available today is the 100% human milk diet based on a fortifier that is produced from donated human milk. In the study published using this particular product, there was a 65% reduction in NEC and no cases of surgical NEC. But keep in mind that the comparative rate was relatively high at 16% NEC rate and was improved to about 6%. The surgical intervention, again, of NEC did drop at 1 from the hospital from 10% to 2.4%. This is an extraordinarily expensive product with an estimated cost of about $10,000 per patient. This product does rely on the donations of human milk for the supply. There is a perceived cost benefit analysis in terms of the cost of surgical NEC being around $200,000. But even in that particular study, you would have to feed 9 patients in order to actually benefit from the reduction. So in looking at some of the other fortifiers that are available, the protein in unfortified human milk obviously is inadequate to meet the baby's needs, and this is the estimation in preterm human milk, which typically does begin to decrease around the 7th to 10th day. And in this slide, you can see that's estimated at 2.1 grams per 100. The powdered fortifiers, which were developed more than 20 years ago, are not adequate to meet the protein requirements for the very low birth weight and extremely low birth weight baby. They're going to be about 1 gram to 1.5 grams short in what the baby requires. Currently, there is a liquid human milk fortifier that does have additional protein added, which, again, estimating the mother's own milk the preterm human milk having 2.1 grams per 100, you would theoretically meet the protein requirements using this product. Another popular fortification method is mixing breast milk with preterm formula that is 30 calories an ounce. And this has become popular because of the desire to remove powdered formulas from the NICU because of the possibility of contamination. The problem with doing this is that we displace 50% of the mother's milk. And as we talked about before, there's a dose dependence on the more mother's milk, the more beneficial for the baby, as well as we are significantly lower in protein than what is desirable. So looking at these fortifiers just in a little more definitive way, again, your 30-calorie formula that is mixed half and half with human milk, the calories are easy to achieve with just about anything that we do, and that has really never been a problem. The problem has been achieving adequate amounts of protein. A common thing to do when using 30-calorie mix with human milk is, because we are inadequate in protein, is to go back and add a secondary source of protein, such as a protein powder, which, again, adding protein supplements in the NICU is not ideal. Other nutrients that are lacking with this formulation is vitamin D. You can see the recommendations of a minimum of 400 international units per day, and to achieve this volume of vitamin D, we would have to give 523 mLs per day, which is obviously well above what this size baby could tolerate. Iron will also be lacking in this formulation. The powdered human milk fortifier, again, was developed years before the very small baby that we are treating today was surviving at the rates that they are surviving, and you could see the level of iron is significantly lower than the desired range. Vitamin D as well is about half of what the baby would require, as well as protein. The liquid human milk fortifier does fare a little better when looking at protein and the addition of the iron, which is a relatively new addition in the terms of human milk fortifiers. The vitamin D may have to be supplemented further because we are about half of the daily recommended 400 international units per day using the American Academy of Pediatrics recommendation. The last column is your donor human milk fortifier that is made from the donated human milk, the pooled batches. Again, calories are relatively easy to achieve. As you can see that adding the 4 calories to the estimation of 20 calories per ounce, we can achieve the calories, but we're going to have to go back and supplement protein, vitamin D, and iron, which may defeat the purpose of using such an expensive product to begin with. So there are some things to consider when fortifying human milk in terms of how do we establish tolerance to the fortification, because we know one of the main reasons we are using human milk is that we advance the feedings more quickly, have less days of parental nutrition, and better tolerance. And so when we do add artificial ingredients such as fortification, we have to do that with care. So keep in mind that trophic feedings need to begin first, and that is somewhere between 10 and 20 mLs per kilo per day, and advancing at the same rate as we advance our feedings. We need to have baseline lab values before the addition of any type of fortification, so we know where the baby began and we know how to adjust accordingly in terms of adjusting nutrients as the baby grows. Fortification is not recommended under 100 mLs per kilo per day. The baby needs to be tolerating 100 mLs per kilo per day well before the addition of the artificial fortifier. Standardizing fortification methods among the staff has been shown to improve the overall outcome in terms of when it's added, how it is advanced, and what types of fortifiers are used. So targeted fortification may be used by following the BUN and adjusting protein as needed. One more point to make about human milk in the NICU setting. As we have encouraged the use of human milk across the country in neonatal intensive cares, one thing has come to light in that we are doing a very poor job of managing the human milk in the NICU setting. Infections have been associated with contaminated or spoiled human milk and with the use of dirty breast pumps and equipment that have not been sterilized or sanitized properly. We need to pay attention to the types of containers so that we do not allow for leaking and spilling and that we protect the milk. It is recommended that plastic or glass bottles with sealable lids should be used and not the plastic bags that have been popular because they are inexpensive. The bags do not protect the milk as well as do not provide an adequate barrier. Where we prepare the milk in the neonatal intensive care is also very important in that we remember that this is food to be ingested by our smallest and most vulnerable patients. And so we need to make sure that the milk is prepared in a separate area that is not in a patient care area. And we need to make sure that our equipment is commercial or pharmacy grade in terms of our refrigerators and freezers so that the milk will be held at an appropriate temperature and not spoiled because that is held at too warm. We need to use sterile fortifiers whenever we have those available to add that additional layer of protection so we're not adding contaminants to the milk. You can find further information on these guidelines in the American Dietetic Association's infant feeding guidelines for preparation of human milk and formula in healthcare facilities, as you can see that here.
So in conclusion, human milk contains naturally occurring components that may protect against neck and infection. Colostrum can be used to aid gut maturation even if the baby is NPO. More studies are needed here. Human milk provides protective qualities not found in infant formula. We need to focus on mother's own milk by providing education, support, and a friendly environment. Donor milk can be used to complement mother's milk, but it is not nutritionally equal to mother's own milk. Human milk must be fortified for the preterm infant, whether it's donor milk or mother's own milk. Guidelines must be followed to prevent contaminating or spoiling human milk. Thank you very much. This ends our webinar.
On behalf of the Annenberg Center for Health Sciences, thank you for your interest in this topic. This ends today's program.